Welcome to Ophthalmology.online. Today, in PG first year series, we will be discussing about anatomy of the eyelid.
Let's know about the development of eyelid. The upper lid will come from mesenchymal proliferation of frontonasal process, whereas the lower lid is from the mesenchymal proliferation of maxillary process. In the above picture, you can see frontonasal process and the maxillary process. And coming to the stages of development, there will be three stages. That is fusion of the lids, next development of the lid structures, you can see in this picture, and eyelid disjunction finally. Let's see eyelid fusion. At the beginning of the week 8, there is a gap between the upper and lower eyelid, and even the cornea is still visible. The process of eyelid fusion will start at around week 8. The flattened peridermal cells you are seeing in the first picture will undergo a morphogenetic and a proliferative change and becomes into a rounded or a cuboidal periderm cells. And now these peridermal cells will advance and proliferate and try to make contact with the advancing edge of the opposing lid peridermal cells, and finally a connection will be established. After the connection is established between the both sides, these peridermal cells will now again flatten and will form a continuous sheet, finally covering the entirety of the cornea. Now, in the second picture, you see only the periderm and epidermal layers are involved in the eyelid fusion, while the eyelid mesenchyme is always remaining distinct. By the 9th week, the development of eyelid structures will begin immediately after the eyelid fusion. Now, the very first structure to appear is the orbital part of the orbicularis oculi muscle. By around 14th week, the eyelid is divided into separate layers. And in this picture, in the second picture, you can see rudimentary eyelashes, sebaceous and sweat glands. And you can near the eyelid margin, if you will see, there is a primordial tarsal plate that is being formed. Here I kept an arrow mark for you to understand. By around week 20, if you see the lower left corner picture, the eyelids are still visibly fused and the separation has already started anteriorly. The meibomium gland branching is the first to be observed and the tarsal plate has lengthened significantly. The orbicularis muscle OO, if you see, it looks more fully developed. Nearly mature follicles are about to pierce the lid margin, which are also evident in this picture. If you'll see the middle picture, that is around week 32, the eyelid has taken its nearly fully developed appearance, and the meibomium glands, if you will see, it has increased in length and are about 2/3 of the length of the tarsal plate. And at full term, if you will see, the final appearance at the eyelids at birth can be seen at the right corner. When there is a defect in the development, like the fusion of eyelids, then it results in eyelid coloboma. If there is a defect in LPS formation, then it can result in congenital ptosis. Euroblepharon and ankyloblepharon are due to defect in the disjunction. In euroblepharon, you see widening of the palpebral fissure, whereas in ankyloblepharon, you see due to improper disjunction of the upper lid and lower lid, you see both the lid margins are attached. This is blepharophimosis syndrome, where you can see shortening of the palpebral aperture, blepharophimosis, and there is a fold of skin coming from the lower lid towards the upper eyelid, epicanthus inversus, and the increase in the distance between the medial cantha, telecanthus, and drooping of the upper eyelid, ptosis. Cryptophthalmos is usually associated with Fraser syndrome, which is characterized by cryptophthalmos, cutaneous syndactyly, malformations of the larynx and genitourinary tract, craniofacial dysmorphism, orofacial clefting, mental retardation, and musculoskeletal anomalies.
Functions of the eyelid. First and foremost function is it protects the eye, and then it acts as a shutter and limits the amount of the light that is entering the eye. And it is also containing some glands which will secrete different components of the tear film that will prevent the evaporation of the tear film and protects the ocular surface. It also distributes the tears over the surface of the globe. So you'll be blinking the eyes. During this process, it will distribute the tear film, and it also moves the tear towards the drainage system.
This is the upper eyelid. It extends from the lid margin towards the eyebrow. This is the lower eyelid. It extends from the lower lid margin towards the inferior orbital margin. This is the upper eyelid crease, and it lies about 8 to 9 mm from the upper eyelid margin in males, whereas 9 to 10 mm from the lid margin in females. This is the lower eyelid crease. It lies about 3 mm from the lower lid margin. This is the upper eyelid crease. This is formed due to attachment of LPS aponeurosis to the skin. This is lower eyelid crease. It is formed due to attachment of capsulopalpebral fascia, but not due to inferior rectus. This is the lateral canthus, and this is the medial canthus. The normal intercanthal distance is 30 millimeters, whereas if it is more than 30 millimeters, it is called telecanthus. Normally, lateral canthus and medial canthus somewhat stay in a same line, but if the lateral canthus is above that of the medial canthus by around 2 mm, then we call it as mongoloid slant. And if the medial canthus is above the level of lateral canthus, it is anti-mongoloid slant. We usually see mongoloid slant in Down syndrome and Noonan syndrome, whereas we see the anti-mongoloid slant in Treacher-Collins syndrome and tripod fracture.
In the first picture, if you see, the entire cornea is not visible. The upper portion of the cornea is covered by the upper eyelid, and it covers about 1/6 of the cornea, whereas the lower lid is just touching the limbus. Now, the exposed ocular surface that is in between the upper and lower eyelid is the palpebral fissure. In a normal adult, this fissure is about 27 to 30 mm long and 8 to 11 mm wide. The upper eyelid, which is more mobile than that of the lower eyelid, can be raised by 15 mm by the action of the levator palpebrae superioris muscle, and it can be raised another 1 to 2 mm by the action of the Muller muscle. And if the frontalis muscle of the brow is used, the palpebral fissure can be widened an additional 2 mm.
Let's see about some lid conditions. The ptosis and reverse ptosis. Coming to ptosis, it is drooping of the upper eyelid. In the top right corner, you can see there is a left ptosis picture, and reverse ptosis is when your lower lid covers a part of cornea, usually seen in Horner syndrome. In the bottom corner, if you will see, there is reverse ptosis. Now let's see lid retraction. If the lid margins are pulled from their normal position, it results in scleral show. If this occurs in the upper lid, then we call it as upper lid retraction. Here you see in this picture there is upper scleral show, usually seen in Graves' disease. In lower lid retraction there will be inferior scleral show. In this picture you can see the inferior scleral show.
In this picture, let us see the structure of the eyelid from the dermal surface inside. First, we see the skin and subcutaneous tissue, below which there is muscles of protraction like orbicularis oculi muscle, which is the main protractor. Next comes orbital septum. Next you can see orbital fat, and then we can see the muscles of retraction, namely levator palpebrae superioris, the Muller muscle, capsulopalpebral fascia, and the inferior tarsus muscle. Next you can see the tarsus, and then there is palpebral conjunctiva. The eyelid skin is the thinnest in the body, and it contains fine hairs, sebaceous glands, and sweat glands. Here, the sebaceous glands are situated more in the nasal portion. A superior eyelid crease is present near the upper border of the tarsus, where the levator aponeurosis will establish its first insertional attachment, and it is loosely adherent to the underlying orbicularis muscle, so it is more mobile. And in cases of eyelid trauma, where there is a breach in continuity, it is very easy to do a primary closure by opposing the two edges, and the loose connective tissue of the eyelid does not contain fat, so the blood and other fluids can accumulate within this region and cause rapid swelling of the eyelid. coming to the lid margin, the small opening, the punctum, which we can see in this picture, that is present medially at the summit of the lacrimal papillae, divides the entire zone into the ciliary zone and the lacrimal zone. The medial 1/6 portion that is behind this lacrimal punctum is the lacrimal portion, and the portion that is after the lacrimal punctum is the ciliary zone. Okay, now the superior punctum is normally hidden, and by slight internal rotation it is located more medially than that of the inferior punctum. Along this entire length of this free margin of the eyelid, you can see there is a delicate gray line. Okay, it is also called as intermarginal sulcus. This corresponds to the most superficial portion of this orbicularis oculi muscle, the muscle of Riolan, and the avascular plane of the eyelid. Anterior to this line, you can see the eyelashes arising, and behind this line there is opening of the meibomium or the tarsal glands, and it is also called as white line. The anterior border is curved, whereas the posterior border is. The lid margin is 2 mm thick and 30 mm long. The lacrimal papillae divides the lid margin into the two parts, ciliary and lacrimal portions. This ciliary portion consists of cilia or eyelashes in the anterior border. Usually, the upper eyelid has more lashes compared to that of the lower eyelid, and these lashes are located in 2 to 3 rows. In the direction in which these eyelashes are facing is, in the upper eyelid, it is forwards, upwards, and laterally. In the lower portion, it is forwards, downwards, and laterally. Next, the gray line, which we can see in this picture, and the white line is nothing but the opening of the meibomium orifice, and the posterior border of the eyelid is sharp. Next, coming to the lacrimal portion, the medial 1/6 portion, the lacrimal punctum, which is visible in the picture, and you can see the plica semilunaris, which is narrow crescent fold of conjunctiva that is present as a floor for the tear lake. You can see in this picture, in the medialmost portion there is caruncle. Just in front of the caruncle there is a crescent shaped fold of conjunctiva. This is plica semilunaris. Next, coming to the caruncle is that small pink mass of the modified skin that is located medial to the plica. Coming to glands of eyelid, the margin contains the gland of Zeiss, which are modified sebaceous glands associated with the cilia, and the glands of mole, which are apocrine sweat glands in the skin. Now, coming to the glands of Zeiss, it consists of usually a single lobe, whereas in the rest of the body, the sebaceous glands are usually multilobular, and these produce a sebum that keeps the eyelashes from becoming dry and brittle. Next, coming to the gland of mole, it lies between the cilia at the anterior lid margin. Not like the gland of Zeiss, it will not open into the eyelash, whereas it directly opens into the lid margin. Usually it is having unbranched and spiral shape. Next, we have accessory lacrimal glands that are cross and Wolfring. These are also located in the eyelid, and these have exocrine secretion, and the content of the secretion is aqueous. We also have eccrine sweat glands that are distributed throughout the eyelid skin and are not confined to the lid margin, in contrast to the glands of mole. Coming to orbicularis oculi, it is a striated muscle, and it is a muscle of protraction. Here, if you are seeing this muscle from the front, you are seeing some circular muscle fibers running throughout in a concentric fashion. Here we are having two parts of the orbicularis muscle. One is the orbital part and the other is the palpebral part. And in this picture, you can see the palpebral part is divided into pretarsal and preseptal. So what is this pretarsal and what is this preseptal portions is, in the second picture if you will see, in the upper portion Just in front of the orbital septum, you can see part of this orbicularis muscle. This part of the orbicularis muscle is the pre-septal orbicularis muscle. And as you go towards the lid margin, you can see the tarsus here. And in front of the tarsus, there is pre-tarsal orbicularis muscle.
Coming to the origin of the orbital part of the orbicularis ocular muscle, in this picture if you can see, it is coming from the medial palpebral ligament, and it will run concentrically around, and it is finally coming and getting inserted into the same medial palpebral ligament. Whereas the palpebral part is having two heads. The superficial head is coming from the medial palpebral ligament, whereas the deep one from the anterior lacrimal crest. And these parts are inserted like the preseptal part is running throughout and finally landing up in the lateral palpebral raphe. You can see this in the picture towards the lateral part. Now the pretarsal portion, it will finally go and join the lateral canthal ligament. Coming to the nerve supply of this, it is supplied by the temporal and zygomatic branches of the facial nerve. Coming to its action, the orbicularis part, the orbital part of the orbicularis ocular muscle has the forceful closure of the eye, that is squeezing and winking, which is a voluntary function, whereas the palpebral portion is having a protective function, that is reflexive blinking. See, when something suddenly comes and falls on your eye, you will suddenly blink. So this is a protective action which can be both voluntary as well as involuntary.
The pretarsal orbicularis muscle adheres firmly to the tarsus. A portion of it attaches to the anterior lacrimal crest and posterior lacrimal crest. This is called the Horner's muscle, and this plays an important role in tear drainage. The contraction of this Horner's muscle will draw the eyelid medially and posteriorly, and thereby it will create a negative pressure in the lacrimal sac area, and then it draws the tear into the sac from the canaliculus, and thus it acts as a lacrimal pump. Now, the orbicularis fibers extend to the eyelid margin, where there is a small bundle of striated muscle fibers called the muscle of rheolon. The rheolon muscle is the one which is forming the gray line. Now, there is one more muscle called Jones muscle. The deeper origin of the preseptal fibers of orbicularis arises from the posterior lacrimal crest and the surrounding fascia. Horner's muscle is called pars lacrimalis, whereas the rheolon muscle is called pars ciliaris.
In seventh nerve palsy, due to paralysis of orbicularis muscle, there will be lag ophthalmos and ectropion, and due to failure of the Horner's muscle and lacrimal pump, which results in epiphora. Let us say what is orbital septum. Orbital septum is nothing but a modification of the periosteum. Normally, the frontal bone will have a lining periosteum. This orbital septum is nothing but the extension of this periosteum. Now, the orbital septum is a thin sheet of connective tissue that is encircling the orbit as an extension of the periosteum of the roof and the floor of the orbit. Superiorly, this septum is attached firmly to the periosteum. You see this thickened margin around this in the picture superiorly, that is arcus marginalis. It passes medially in front of the trochlea, and it is continuing along the medial margin of the orbit. Now, along this margin of the frontal process of the maxillary bone, and then it will move on to the inferior margin of the orbit. Now, centrally, the orbital septum will attach to the aponeurosis of both the upper and lower eyelids. What is the importance of this orbital septum is that it is delimiting the anterior and posterior spread of edema, inflammatory fluid, blood. See, some of the examples are like preseptal cellulitis, orbital cellulitis.
Coming to the structures piercing the septum orbital are lacrimal vessels and nerves, supraorbital vessels and nerves, supratrochlear artery and nerve, infratrochlear nerve, superior and inferior palpebral arteries, and apart from this, there will be anastomosing vein between angular and ophthalmic vein, aponeurosis of the LPS in the upper eyelid, and expansion of this inferior rectus in the lower eyelid. Coming to orbital fat pad, it lies between the levator aponeurosis and the orbital septum. In the upper eyelid, there are two fat pads, that is medial fat pad and the central fat pad. In the lower eyelid, there are three, that is medial, central, and the lateral fat pad. In the upper eyelid, laterally there is lacrimal gland, which might be confused for fat pad. Now, in the lower eyelid, the inferior oblique muscle passes in between the medial and the central fat pad. And the way to identify this medial fat pad and central fat pad is the medial fat pad in the lower lid is bit paler compared to the central fat pad. And the clinical importance of this fat pad is during any trauma, like any laceration to the lid, if you are seeing the fat prolapse, then it is an indication that the orbital septum is injured.
Levator palpebrae superioris muscle is a skeletal muscle and it is a muscle of retraction of the eyelid. Its origin is from the lesser wing of sphenoid bone at the orbital apex, and the body of this levator muscle will lie over the superior rectus as it is traveling anteriorly towards the eyelid, and this portion is about 40 mm long and it is supplied by the third nerve superior division, and the action of this muscle is to lift the upper eyelid. Here in this picture, if you are seeing, the green portion is this LPS muscle. From the orbital apex, it is traveling anteriorly, and at a point where the facial sheath around it will condense into form a Whitnall's ligament, there it will suddenly turn vertically. So until this Whitnall's ligament, the function is in the anterior posterior direction, whereas from this Whitnall ligaments, which acts as a fulcrum to this muscle, it will be working in the vertical direction, superior to inferior. The Whitnall ligament or the superior transverse ligament, if you can see in this first picture, there is the condensation of the fascia around the levator palpebrae superioris that is forming the Whitnall's ligament. So at this Whitnall's ligament, the levator muscle will transition into two portions, that is the anterior part which you are seeing here is the levator aponeurosis, and if you are seeing in the second picture, there is a muscle that is coming behind this. So this is the Muller's muscle, which is a smooth muscle. It is also called as superior tarsus muscle. Why? If you can see in this picture, it is going and joining the tarsus. Okay, the Whitnall's ligament is also where the levator muscle's anterior posterior vector changes to superior inferior, which I told in the previous slide. Now, the levator aponeurosis, the tendon of the levator muscle that is around 14 to 20 mm in length, and it is having many attachments to the eyelid and surrounding orbit. Do you remember we spoke about superior eyelid crease? So that is where the attachment of the levator aponeurosis. Now this is an anterior attachment. Now posteriorly, the levator aponeurosis inserts into the surface of the tarsus. This aponeurosis is firmest attachment on the anterior aspect of the tarsus, approximately 3 mm superior to the lid margin. LPS aponeurosis also inserts into the trochlea of the superior oblique muscle, thereby bridging the superior orbital foramen. The lateral horn of the aponeurosis divides the lacrimal gland into orbital and palpebral lobes, and it inserts at the lateral orbital tubercle. The medial horn will insert at the posterior lacrimal crest. These aponeurotic attachments also exist with the conjunctiva of the upper fornix and the orbital septum. Let's see what happens in the levator palpebrae superioris palsy. So you know levator palpebrae superioris is the main levator of the upper eyelid. So it results in ptosis. You know already what ptosis is. So now there will be conditions like congenital ptosis and aponeurotic ptosis. You know congenital ptosis, here the muscle is dystrophic, so there will be absent lid crease. But in aponeurotic ptosis, you will be having at a higher level because it can be due to dehiscence also. So now the thing comes, how do you differentiate between congenital and aponeurotic ptosis? If you'll see the levator function, usually in the congenital ptosis, it is reduced, whereas in aponeurotic ptosis, it is near to normal. And the main test to differentiate it is when you ask the patient to look down, there will be lid lag in case of a congenital ptosis, whereas when it comes to aponeurotic ptosis, the lower lid margin will be at a much lower level compared to that of a congenital ptosis patient. The muscle, it is also known as superior tarsal muscle. It originates from the undersurface of the levator palpebrae superioris muscle in the upper eyelid. You know there is a Whitnall ligament where LPS will be giving into aponeurosis, and posteriorly it gives Muller's muscle. This is a smooth muscle and it is innervated by the sympathetic nervous system. Its action is about 1 to 2 mm lifting of the upper eyelid, and the Muller muscle will attach to the upper border of the upper tarsus and the conjunctiva of the upper fornix. Now, in conditions like Horner's syndrome, where there will be sympathetic innervation will be affected, there will be paralysis of the Muller muscle, which leads to mild ptosis of about 1 to 2 mm of the upper eyelid. Whereas in conditions like thyroid orbitopathy, where there will be increased sympathetic discharge, there will be lid retraction. We know in the upper eyelid we have LPS and Muller muscle as retractors. Similarly, in the lower eyelid, the capsulopalpebral fascia is a retractor that is analogous to the levator aponeurosis, and the inferior tarsal muscle. The inferior tarsal muscle arises from the capsulopalpebral head of the inferior rectus muscle in the lower eyelid. Just like the Muller muscle, the inferior tarsal muscle is a smooth muscle, but it is much weaker than that of the Muller muscle. It attaches to the lower border of the lower tarsus. The inferior equivalent to the Wittnall's ligament is the suspensory ligament of Lockwood, which is a fusion of the sheath inferior rectus muscle and the inferior tarsal muscle and the check ligaments of the medial and lateral rectus muscles. Here in this picture I have rounded. So let's see about tarsus. See, the tarsal plates are made up of a dense connective tissue. These are attached to the orbital margin by the lateral and medial canthal tendons. Now, the upper and lower tarsal plates are almost similar in width, that is about 29 millimeters, and thickness of about 1 millimeters. But the height of the upper tarsus is about 11 mm, and it is almost 3 times greater than that of the lower tarsus, which is only 4 mm. Okay, now coming to the glands that are situated within the tarsus, that is meibomium glands, also known as the tarsal glands. These are a type of modified holocrine sebaceous glands. Okay, and these are present vertically in parallel rows. So that is the reason while we are doing a chalazion excision and all, we will be giving a vertical neck, so not to damage these things. Okay, now this distribution is about, like, in a single row there will be about 40 meibomium glands. Okay, and the number of orifices, if you will take in the lower lid, it is only 20 to 30 as compared to the upper lid, which is about 40. So how can we see this? Through infrared imaging of the eyelid. Next, what is the importance of this? So the oil or mebum that is secreted from these orifices will form a reservoir on the skin surface of the eyelid margin, and then during blinking process what happens is they will spread onto the tear film, and any alteration to this, like meibomium gland lipid composition, which leads to dry eye. So it is of a major importance in treating dry eyes. Let's discuss about attachments of the tarsus. So if you'll see the superior tarsal border in the upper eyelid, the attachments are, one is orbital septum, that is anteriorly, and Muller's muscle posteriorly. Coming to the inferior tarsal border, if you'll see the picture below, the area I marked, one is the orbital septum, next is capsulopalpebral fascia, and the inferior palpebral muscle. In this picture you see the capsulopalpebral fascia is formed like the fibers from the inferior rectus muscle will extend forward, and then they are enveloping the inferior oblique muscle, finally forming the Lockwood ligament. And this continues anteriorly to attach to the orbital septum and the inferior conjunctival fornix and inserting onto the inferior tarsal border. Let us see the canthal tendons. We have two canthal tendons, lateral canthal tendon and a medial canthal tendon. This lateral canthal tendon has two limbs, superior and inferior, whereas the medial canthal tendon has three limbs. One is anterior, superior and posterior. The lateral canthal tendon, the two limbs give the shape of the canthus. Similarly, in the medial canthal tendon, the posterior and the superior limb will give the shape, whereas there is an importance for the anterior limb. The anterior limb of the canthal tendon is the one that is helpful in identifying the lacrimal sac in DCT procedures. Okay, and what is the importance of lateral canthal tendon? It is used for doing cantholysis in cases of any compartment syndrome where there will be increased retroorbital pressure. Like it is an emergency situation where you need to do a lateral cantholysis. Now let us speak about the posterior most layer of the eyelid, that is conjunctiva. It is formed by the palpebral conjunctiva. It is so firmly attached to the tarsus that it is impossible to be separated by manual dissection. Now, this palpebral or tarsal conjunctiva is a transparent vascularized membrane consisting of non-keratinized stratified squamous epithelium that lines the inner surface of the eyelids and is continuous with the conjunctival fornices called cul-de-sacs. It merges with the bulbar conjunctiva before terminating at the limbus. Now, the conjunctiva is also containing some accessory lacrimal glands. These glands are present in relation to the eyelids and are called glands of Wolfram, and these are present along the superior border of the upper tarsus and inferior border of the lower tarsus. And there are some glands called glands of cross that are present at the fornices. These lacrimal glands are accessory lacrimal glands. These produce basal tears. Let us discuss about the vascular supply of eyelids. The blood supply of the eyelid is mainly derived from the facial system that is arising from the external carotid artery, whereas the orbital system that is originating from the internal carotid artery along the branches of ophthalmic artery. Here, the eyelid vasculature represents an anastomosis of external and internal carotid arteries. Particularly in eyelid vascularity, you should know about marginal arterial arcade that is located about 3 mm above the free border of the eyelid, just above the ciliary follicles. Okay, it can be either present within the tarsus or between the tarsal plate and the orbicularis oculi. So coming to this picture, if you will see, it is having numerous vessels. Amongst them, if you can see, the facial artery is giving rise to an angular artery and it is traveling superiorly just lateral to the nose. This angular artery will serve as an important landmark in DCR. And coming to the venous drainage, the eyelids can be divided into two components. One is a superficial or a pretarsal system that is draining into the internal and external jugular veins, and a deep or a post-tarsal system which falls into the cavernous sinus. So it is very important to know that this venous circulation of the eyelid will connect the face with the cavernous sinus, providing a route for the spread of infection. Now let us see the lymphatics of the eyelid. Usually the lymphatics are present in the eyelids, the conjunctiva and the orbit. The lymphatic drainage from the eyelids usually parallels the course of the veins. There are two groups of lymphatics. One is a medial group and one is a lateral group. The medial group drains into the submandibular lymph nodes and the lateral group drains into the superficial periauricular lymph nodes. Clinically, the swelling of these lymph nodes is a diagnostic sign of the several external eye infections including adenoviral conjunctivitis. Thank you. I hope this presentation helps you in understanding the concepts of eyelid anatomy. Please let me know in the comments if there is any questions or queries so that I can answer you in the coming episodes.